This is going to be bundle branch blocks and mimics. Topics we're going to discuss here are going to be bundle branch blocks, and these are all mimics of ST segment elevation, left ventricular hypertrophy or LVH, paced rhythms, pericarditis, and early repolarization. As far as treatment goes, you need to treat your patients clinically. So even though you found a mimic, if the patient has chest pain, shortness of breath, and is diaphoretic or looks like they're having an MI, treat them clinically with ACS algorithms or acute coronary syndrome algorithms. So again, please err in your patient's favor. Even though you found a mimic, you treat the patients clinically or off of their clinical presentation. Bundle branch blocks. We're going to show you how to determine a bundle branch block very rapidly, whether it be a left bundle branch or a right bundle branch block. The technique used here is called the turn signal method. So what we're going to do here is we have to have some specific criteria. First of all, you have to have a supraventricular rhythm, and then whenever we talk about supraventricular rhythms, what we're talking about is anything that is above the ventricles. So if it's essentially at the AV node or above, the beat comes from there. So that includes sinus tach, sinus brady's, sinus rhythms, any atrial fib, atrial flutter, SVTs are all in this category, supraventricular tachycardia. So it needs to be above the ventricles. That would include even the junction here. That includes junctional rhythms of any sort. So anything above the ventricles, and the QRS complex as a part of this needs to be wide. Now we used to call these interventricular conduction delays. So what that means is that our QRS duration is greater than 0.12 seconds or 120 milliseconds. Now you must use V1 or MCL1 for this theory to work. If we viewed modified chest lead 1, then we've placed one of our leads at the V1 level, and that would be considered modified chest lead 1. We're going to look at the direction of the QRS in V1 or modified chest lead 1. Alright, so now in V1 we find the J point and we draw a line into the QRS until it's halfway through the previous wave. So an example of this, if this was the previous wave and this is the J point here, I would draw a line halfway through the previous wave and a point to the apex of that complex, no matter if it's up or down. Kind of draw an arrow is always helpful too, so I can see which direction it is. Now, this technique suggests shading in an area. It's just so that you can see the direction of that previous wave. And this one is below the isoelectric line. So the turn signal method is very simply like you would use your turn signal in your car. So if you push up on the turn signal, you're making a right-hand turn. And if you push down on the turn signal, you are making a left-hand turn. So if this previous wave is below the isoelectric line, then that would be a left bundle branch block. If it is just the opposite of that, this is our J point. And the arrow is always a lot easier for me, or you can shade it in. But this would be going in this direction. That would be a right bundle branch block. It's called the turn signal method. Very simply, V1, our QRS has to be greater than 0.12 seconds or 120 milliseconds. We find our J point. If the previous wave is above the isoelectric line, the apex of it, then it's a right bundle branch block. If the previous wave is below the isoelectric line, then it is a left bundle branch block. Interventricular conduction delays like this will show up in various locations sometimes as ST segment elevation, but it's a mimic. We can't tell if they have one of these mimics whether or not the patient is actually having ST segment elevation from the injury or is from the mimic. So again, treat your patients clinically or off of their clinical presentation until proven otherwise. Now, if you have the ability to run a rapid troponin, then run the rapid troponin and figure out whether or not there has been a release of cellular material from the myocardial tissue. Example 1 here, and this is V1. This is our J point. And we are above the isoelectric line. So this would be like pushing the turn signal up or taking a right-hand turn. And this is a right bundle branch block. Give you another example here really quick. V1 to the apex. This is going to be like pushing the turn signal down or making a left-hand turn. And this is a left bundle branch block. Now, another telltale sign, I'm going to back the slide set up for just a second. We tend to see across our V leads this RR prime somewhere, even if it's like this, has an RR prime, and that's kind of indicative of a person having a bundle branch block. But we're going to use the turn signal technique to identify which one they have. Same way with this, if we'll kind of look out across here, we see RR primes in the V leads and the interventricular conduction delay. Or it takes time once the electricity finds that block to go around the surrounding tissues. So if the arrow points upward, it would be a right-hand turn, and if the arrow points downward, it would be a left-hand turn, and the associated side bundle branch block along with it. So right-hand turn, right bundle branch block, left-hand turn, left bundle branch block. We should not try to find acute ST segment elevation in a left bundle branch block. It's going to have some, and I'll back up again. This here, we are only looking for really about 1 millimeter. That could trick us, and on a real person, sometimes it's much more than that. It'll be 1 or 2, pop on over, look something like that. So anything that would look like that, we don't know if it's real or not. All right, other mimics that we're going to look at here: left ventricular hypertrophy, paced rhythms, pericarditis, and then early repolarization. All of these are mimics, or can mimic ST segment elevation. All right, this is left ventricular hypertrophy. And one of the techniques of looking at LVH, or looking for LVH, is to find, we look at V1, and we look at V6. And if the combination or the addition of the QRSs, and it's more specific, it's the S wave in V1 and the R wave in V5 or V6. If the R, and I'll mark these off the R wave. And then this is the S wave. So this is what we're looking for. And this R wave up here is very, very high. It goes into the previous wave. This one's high as well. So whichever one is taller. This one in V5 is taller. So I think I would use that one. So the total combination of these two, whichever one we pick, V1, V5, or V1, V6, is either equal to or greater than 35 millimeters. Now, what that does is that's a lot of area that the electricity has to travel through. So the left ventricle, since we're primarily getting a left ventricular look, is larger. Now, another telltale sign before we start adding these up is this QRS dipping into, this QRS goes all the way into to the next wave. And simultaneously, this one in V3 here is all the way down into our rhythm strip at the bottom. Same way with V5, it's all the way up into V4. So if we see that pattern to where the QRS is dipping into the next wave, that's also another telltale sign of, well, maybe I should look at V1, V5, V6 and figure out if they have left ventricular hypertrophy or not. 7 squares total, large squares. Each one of these squares that I'm going to draw out here has 5 millimeters in it. So each one of those, if it is equal to or greater than 5 times 7 is 35. So let's count these off. This one's about plus or minus 1. I was going to call that 1, 2, 3, 4, because we get 1 down here. So that's definitely 4, or 20 millimeters. And then this guy here in V5 is the largest of my QRSs. And I'm looking for the R wave, which is all the way up here. 1, 2, 3, 4, 5, 6 and a half. So this is 30. At least. So 30 plus 20 is 50. So the question is that equal to or greater than 35 millimeters? And the answer is yes, it is. So this person here has left ventricular hypertrophy. And I'm going to point out a few things. I'm going to get rid of all this. I can't tell at this point if this ST segment elevation is him actually having an injury or it's the LVH. So I'm going to treat this patient clinically. I'm going to treat them exactly. If they're complaining of chest pain and it's 9 on a 10 scale, I'm going to give them the whole 9 yards and hopefully have a reduction of pain and treat him appropriately. If you have the ability to send a 12 lead in, then we should send a 12 lead in and get it evaluated by the physician. If it's at the hospital of their choice, they generally will have 12 leads in the computer or in their systems that they can compare this against. They can look at our height of ST segment elevation and what they had on their ST segment elevation, or what appeared to be ST segment elevation on their 12 lead, and compare the two. If there's more in our version, they may call us back and say, hey, go ahead and upgrade or go ahead and keep coming hot. I don't know, or I can't tell yet if this person's having an MI or not either without a troponin. Ventricular paced rhythms. Everyone will kind of make note of this right here. You can see the spike probably the best. Now, a ventricular paced rhythm can give us things that look like ST segment elevation. But since it's outside of the pathways, can't really tell if it's truly ST segment elevation or not. So this is another mimic. I'm going to show you a technique in the next slide set on how to ascertain whether or not a person is having an MI in a mimic. It's called Sgarbosa's criteria. But this person here, with this initial look, I'm going to have to look deeper to figure out if they're having true STEMI event or they're having a mimic. With each one of these, please remember, treat your patient clinically. This is EKG criteria for pericarditis. We have ST segment elevation. It's concave, which means this. Nice little scooping action in all leads. T-wave elevation and PR depression. And it has a tendency to look like, if we drawed a couple eyes on it and a circle, kind of a smiley face or a smiley pattern. Now, one of two things. Either this person is having a global MI. It's really, we have a bumped ST segment here, 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 and bumped here. So, one other characteristic of pericarditis is it's everywhere. This does look like a telltale sign, so if I made a little smiley face on this. So smiley face design, again, treat your patient clinically. They're having chest pain. Until you can get them to more diagnostic areas, please treat them as they're having chest pain. As far as diagnosis goes, this physical criteria, chest pain relieving criteria, is pleuritic in nature. Hurts more during palpation. No response to nitroglycerin. They have a pericardial rub if we're listening in the area of S1 for S1, S2. EKG changes that do not localize, we can't see them in a specific pattern like septal, anterior, lateral. They're everywhere. And they have a telltale sign of a smiley face. Again, this one's awful large. And it's everywhere. V1, V2, V3, V4, V5, V6, lead 1, lead 2, lead 3. We still have a little bit of bumping looking in lead 3. So they're either having the biggest global MI that you've ever seen, or they may be having pericarditis. Err in your patient's favor. Cannot elaborate on that enough. Early repolarization. Early repol is noted, it has kind of the same smiley face looking stuff to it. Only early repol has this notched J-point. So instead of a physical J-point, which the J-point here would have been right about there, it's got this little notch in the down wave of the S wave. So we look for this notched J-point and consider it may be early repolarization. Generally occurs in young and healthy people, African American males. It has a distinctive notched J-point and a concave elevation, the same thing that we saw with pericarditis. We generally see this in leads 2, 3, AVF, and V4 through V6. Most of the people that we discover with this won't have chest pain. This is young, healthy people that don't have cardiac issues yet. And sometimes we can even see them in the lateral leads. So over the next areas, I'm going to point out let you look at some 12 leads with me, and these are in your workbook as well. So if you printed off the workbook, please go through them as well. These 12 leads, there's a mimic in all of them. So I'm going to point out the mimic so that you all get a little sick time at looking for mimics in each one of these. So this is practice number 1. And we should start to get into our 3-step process right now. So step 1 is rate and rhythm. So we have 95 beats per minute, and it's looking pretty regular. Well, this is a little irregular. P-wave axis is 2,407. It appears to be irregularly irregular at this point. I would need a rhythm strip to confirm this, but I'm going to call it AFib. That would be step 1. Step 2, 91 degrees. And I'm going to double check the computer's work. So I'm seeing this up, up, up. I'm calling it normal axis. And I'm going to need to look for a mimic. So in the same spot, I'm looking at the QRS duration of 140 that's greater than 0.12. I do have a little RR prime action here, and we talked about that in bundle branch blocks. So let's find her J-point here. Do I see anything else? I got kind of a wide, bizarre QRS. So let's find our J-point in V1. And the answer is I have a right bundle branch block that may be causing this interventricular conduction delay or inverted T waves. Now again, I'm going to err in my patient's favor. If they're still having chest pain, I'm going to treat them like they're having an acute coronary syndrome until proven otherwise. Practice number 2. And this is one of the telltale signs that I told you that the QRS would be going into the next wave. So we look at the S wave on V1. And we look at the longest version of the R wave in V5, V6. I think we're going to hit our criteria. as far as this is almost 2, so let's do this one. This one looks like the longest one. From there to there. 1, 2, 3, say 4, 5, and so questionable. He's just a little under. I have 5, which is 30. He's at 34 by my calculations. 1, 2, 3, 4. Right at about 30 by my calculations. However, I have a QRS duration of 170. So let's go through our steps. Step 1, rate and rhythm. I got an upright P wave. PR interval, it says, is greater than 0.20. Looks pretty large in there. Looks pretty long. So first degree AV block. Sinus rhythm with first degree AV block is more correct. Step 2, up, down, down, or negative 49 degrees. I have a left axis deviation. Looking for a mimic. LVH didn't pan out, but it does have this telltale pattern of creeping into the next wave. Questionable LVH at this point. However, I do have a bundle branch block, more specifically a left bundle branch block. And if we'll notice here, so left bundle branch block is part of part 2 there. All of this, I can't tell if it's old, new, or whatever. Now, I'm going to show you a technique called Sgarbosa's criteria in the next slide set. Like I said, this may help you determine whether this might be acute or not. However, err in your patient's favor. Alright. So step 1, machine says 86, up, down, down, upright P wave, PR interval less than 0.20, sinus rhythm. The second one, left axis deviation, and R prime 128 greater than 0.12. Left bundle branch block. And again, I can't tell. By seeing this, I would say that this person probably has LVH. Good chance. Good chance. However, we do not hit the criteria off of the S wave and the highest R wave in V5 or V6. Practice number 4. "83 beats per minute." Machine says 51. Above. Mostly above. So up. 1 is sinus rhythm. 2, normal axis. Second part of 2, looking for any kind of mimic. QRS duration is greater than 0.12 or 120 milliseconds, 132. Our J point, this would be a right bundle branch block. So I don't know if all of these larger than life T-wave ST segments here are old, new. Again, if my patient's having chest pain, please err in their favor. So left bundle branch block, or my apology on this one. this person does have a right bundle branch block. And we got one other thing that we can see here as far as mimics go, which is a notch J point. This person has a little bit of early repole. Alright, practice number 5. And I'm going to change colors since this one's way pink. Change my ink color to blue. Alright, so I got some ST segment elevation there. It looks bumped there. Looks bumped there. Bumped there. Bumped. Elevated. And I can probably see it the best here. And it's everywhere. Again, err in your patient's favor. This is pericarditis because it's in all leads. Both sides of your reciprocal change teeter-totter are elevated on this individual. 6th, this is kind of a tricky one here. But if you look really close, and it may be difficult, you can probably see this better if you printed off the practice section on this. There's a pacer spike right there. So this is a pace rhythm. Unknown if this is old or new. You see it pretty good there too. You can see it there and there. Alright, in conclusion, we use the turn signal method to identify bundle branch blocks. The other mimics, even though we find them, we are going to err in our patient's favor. And last but not least, please err in your patient's favor. We do not want to talk ourselves out of acting aggressively on someone that's having an acute MI. So take these into consideration, risk versus benefit, but if they possibly are having an MI in any form or fashion, that's the highest risk. So err, treat them just like they're having chest pain, err in their favor. References from this were taken from Professional Paramedic Volume 2, Medical Emergencies, Maternal Health and Pediatrics, Del Mar Learning, Green, 12-lead EKG Confidence, 2nd edition, a step-by-step guide, and then Page, 12-lead for Acute Critical Care Providers, 2006, by Pearson Education. If you have any questions concerning this slide set, please feel free to give me a call. My name is Roy Smith, smithart@SamaritanEMSOK.com, or 405-492-8243. Thank you.